So here we can see a medial-femoral condyle defect which is being prepared for microfracture on the right knee. Initially the chondral defect is curetted with a small curette, removing the loose pieces of cartilage, revealing the bone underneath. All of the abnormal cartilage, which is loose and detached from the femur, is removed, taking the cartilage defect back to a stable edge. This technique involves the use of the sharp edge of the curette digging into the cartilage defect at its periphery and trying to leave behind any stable cartilage. The side of the curette is used to probe the edge of the cartilage defect, just to ascertain whether or not the cartilage that's about to be removed is unstable or not. Here you can see that the cartilage is lifting off and moving in an abnormal way. To improve visibility, every now and then the shaver is inserted and the loose pieces of cartilage are removed, giving a much better visual field and enabling a better assessment of where the stable margin of the defect is. The loose flaps can also be removed with the shaver like this, allowing a nice smooth edge to the stable defect, exposing the subchondral bone. And you can see the top left of the defect, a small area of bleeding. And when blood gets into the arthroscopic view, the image obviously becomes slightly worse. So this careful use of the suction, just to use the suction and then flick it back off again, helps minimise this problem and allow it maintain a good view of the defect. So again, the curette is reinserted, the edge of the defect is probed. Here you can see that the defect is still unstable at its superior margin, and so the cartilage is lifted and raised with the curette, trying not to remove any good cartilage. There is a fissure running superlaterally from there. You can see that that large piece of cartilage is still unstable, and so it has to go, even though superficially, certainly on its top surface, it looks good. You have to have cartilage that's attached to bone circumferentially. The curette then takes off the loose parts all the way back to a very stable cartilage rim. And again, visibility deteriorates as the loose pieces of cartilage float around in the view, and therefore the shaver can be reinserted to remove those loose pieces, improve the view. And it's also important to try to avoid leaving loose chondral flaps floating around within the knee between the bearing surfaces, as these can often cause loose body symptoms subsequently. Therefore, now that the defect has been nicely prepared, smooth edge all the way around with exposed subchondral bone, all the loose bits removed, and here these small pieces that floated off towards the back of the knee are just removed whilst trying not to damage the articular surface of the meniscus with the shaver. The microfracture awl is then inserted to the defect, and you can see here on the inferior portion of the defect the bone is very soft and the awl sinks in without any tapping or impaction. The spacing of the microfracture holes is 2 to 3 millimeters apart. You have to take great care not to have a fracture propagate between the two holes, which can destabilize the subchondral bone and cause a bony healing response. And that is one of the things that can lead to osteophyte formation within the defect during the healing process. The ideal healing process with this would be with fibrocartilage to fill the defect. Bone would be less desirable. Here you can see the defect is having microfracture holes made all the way around the periphery, again leaving a spacing of 2 to 3 millimeters between each one, and then the final hole is prepared in the centre, again taking care to be equidistant so that the risk of fracture into one of the other microfracture holes is reduced. Finally, the shaver is once again inserted to remove the small piece of cartilage sitting in the middle of the defect. Post-operatively, the patient undergoes